We now move to menopause. Here's our case. A 53-year-old woman complains of hot flashes, vaginal dryness, irritability. Her symptoms started a year ago, getting worse. Her last gynecologic exam was 2 years ago. Mammogram, normal. When we look at the age of menopause and lifespan, you can see prior to 1900, most women didn't live long enough to experience menopause, which is the dotted line here. You can see as life expectancy has gone higher, what percentage of a woman's life now is going to be after menopause? And you can see it's going to be about a third. Is this going to be a happy time or a sad time? We want it to be a happy time, a good time. Definition of menopause. It usually occurs age 40 to 60, mean age of 51. In 98% of women, it will occur between these years. It is genetically determined. The age has not changed like the age of menarche has. It is unaffected by pregnancy or oral contraceptive pills. You think if you're not ovulating, maybe the eggs would last longer. That's not true. 1,000 are made atretic every month, regardless of whether there is pregnancy or oral contraceptive pills. Smokers, you will have menopause 2 years earlier. If it occurs between ages of 30 to 40, we call this premature menopause. That's rare, 1% of women. Most of it is idiopathic, which means I don't know. It could be from radiation therapy, which has destroyed the follicles in the ovary, or it could be she had surgical removal of the ovaries. But most of the time, when ovaries are left in place, it's idiopathic. If it occurs less than age 30, that is called premature ovarian failure. And now you need to be concerned, could there be an autoimmune etiology, or could there be a Y chromosome mosaic? And one of the concerns with Y chromosome mosaic in the ovaries is that you could have gonadoblastoma developed, or cancer. Perimenopause is the 3 to 5 years preceding menopause, when the menses become anovulatory and will decrease in frequency, and finally they will cease altogether. If we look at the number of oogonia, during a female's life when she was in utero, the maximum number of oogonia, about 6 to 7 million, will be about 20 weeks gestation. Then they rapidly decline in number until at birth a female neonate will have about 1.5 million. Those continue to decline until at the age of puberty, there is about 450,000. And from puberty, every month, 1,000 are gone. And they will continue to decline. And when they are all gone, no functional follicles remain. That is what we call menopause. The average age of menopause, you can see, is, in 50% of the time, age 51. The diagnosis: serially elevated FSH levels for 3 months establishes that you've got menopause, even if she's on hormone replacement, because there is no inhibin to suppress the FSH. And the levels of estrogen that we give for hormone replacement isn't enough to suppress this. The etiology is lack of functional follicles. Age 51 is the mean age. The most common symptom, 100% of women will have amenorrhea, but not all will have hot flashes. Why not? Because obese women have peripheral conversion of adrenal androgens into estrone, and they have enough estrogen on board so that they don't have hot flashes. However, they have an increased risk of endometrial cancer, increased risk of breast cancer, although they have decreased risk of osteoporosis. When we look at the effects of estrogen deficiency, they can be early, they can be intermediate, and they can be late. The early symptoms are hot flashes, sweating, insomnia, menstrual irregularity, and psychological symptoms. The intermediate are vaginal atrophy, pain with intercourse, incontinence, and skin atrophy. But in terms of life-threatening conditions, these are the ones which are life-threatening. These are the late ones. This is from age 60 on: osteoporosis, fractures, coronary heart disease, cardiovascular disease, and Alzheimer's. Almost every organ system is affected by menopause: reproductive tract, urinary tract, psychological. Big concerns are cardiovascular disease, which is the most common cause of mortality in postmenopausal women, and osteoporosis, which is decrease in trabecular bone density. When it reaches a certain threshold, then you can have pathological fractures. So you can see the brain, the heart, the blood vessels, almost every organ in the body is affected by estrogen. Let's look at osteoporosis. Now, this is not important for you to remember the numbers, but it kind of gives you a sense of the seriousness of the problem. 400,000 vertebral fractures annually in the U.S., 300,000 hip fractures, 100,000 radius fractures. 15% of women with hip fractures will die within 6 months because of the immobilization, the deep venous thrombosis, and pulmonary embolism. 50% will lose the capacity for independence and will be in a nursing home for the rest of their lives. So prevention of osteoporosis is very important. Normal bone, osteoporotic bone. And you can see it's the trabecular bone, not the cortical bone, which is affected. This looks like it's moth-eaten. And even just a simple fall can result in a pathological fracture. The location of the fractures are more commonly in the vertebra, number 1, number 2, hip fractures, and number 3, wrist fractures. You can see what happens to the spine. We have a loss of normal contour, and we have this dowager's hump, kyphosis. Look at what happens to her height. She loses height. You can assess bone density using a dual energy X-ray absorbed geometry scan, DEXA scan. This is of the hand. You can do it of the femur. You can do it of the vertebral bodies. And the bone mineral density is reflected as a T-score. A T-score which is up to -1 is normal. Between -1 and -2.5 is osteopenia. Less than 2.5 is osteoporosis. So bone mineral density is going to be important. Who should undergo bone mineral density testing? All women over 65, younger women who have risk factors, and postmenopausal women who present with fractures should undergo bone mineral density. This slide shows on the vertical axis the bone density, and on the horizontal axis time. And you can see that you'd like to start menopause with as high a bone density as possible. The fracture threshold is this red line right here. You'd like to start out as high as possible and have as slow a reduction of bone density. And yet all postmenopausal women will have a decrease in bone density. We can check the current bone density, in other words, where you are on this axis, by doing the DEXA scan. And you can tell what the rate of bone loss is by doing a 24-hour urine collection with NTX, which is N-telopeptide of cross-linked collagen. It's probably not important to remember that, but you do an NTX urinary collection. Risk factors for osteoporosis: family history, thin white female, steroid use, low calcium intake, smoker, alcohol. Which of these can you voluntarily change? Alcohol, smoking, calcium intake, and avoid steroid use. Family history is probably a significant factor which cannot be changed. And here you can see this is the hip fracture, and here you can see the dowager's hump of this elderly, thin, white female. Bone density is greatest at around age 30 in both men and women. Men typically have a higher bone density. And then you're going to have a loss that over time is going to get worse and worse. But you see, women are always going to be lower than men. There is this gender difference. You can see women can reach a fracture threshold as early as their 50s, whereas men typically don't reach a fracture threshold until their 80s. But this is largely a woman's disease. Osteoporosis prevention, calcium and vitamin D intake. The average woman gets only a third of the calcium that she should have. Weight-bearing exercise is helpful. Walking. Stop cigarettes and alcohol. And in terms of medication, there's no question estrogen is the gold standard for osteoporosis prevention. It can replace bone twice that of these other medications, such as the bisphosphonates, which is alendronate and risendronate, or the selective estrogen receptor modulators, which is raloxifene. But estrogen, as we will see, has got some bad press lately. This shows the effect on bone mineral calcium, or density, with a placebo group and estrogen over time. And you can see that there is an increase in bone density with estrogen replacement. When we do the crossover study, and you have half are kept on the medication and half are put onto the placebo, what happens? Those on the estrogen continue to gain, those on the placebo decrease. And it's the same with the placebo group. So there's no question that estrogen is beneficial in terms of osteoporosis. Risendronate is used for bone density, and this is a bisphosphonate. Raloxifene is a selective estrogen receptor modulator. The trade name is Evista. Selective estrogen receptor modulator is a molecule that binds with high affinity to estrogen receptors, has tissue-specific effects distinct from estradiol. For instance, estrogen agonists, they will increase bone density. They will increase serum lipids. Estrogen antagonists will have adverse effects on endometrial tissue, on breast tissue. So with the raloxifene, it will increase bone density, but it does not stimulate the endometrial tissue because it's an estrogen antagonist. But if we look at tamoxifen, tamoxifen will have an estrogen antagonist effect on the breast, but it has an estrogen agonist effect on the endometrial tissue. So these are some of the, quote, designer estrogens which are now being used. Interestingly, raloxifene has no impact on hot flashes or vasomotor symptoms. If you ask a woman, what is she afraid of dying from? Most women will say, breast cancer. But if you look at actual numbers, what do most women die from is cardiovascular disease, not breast cancer. So we need to look at that. This looks at age-adjusted death rates for white women and black women. Coronary heart disease, stroke, lung cancer, breast cancer. And you can see coronary disease is by far the most common. So let's look briefly at hormone replacement. This is a very politically correct slide. We have a Caucasian, an Asian, and a black woman. Estrogen therapy. This was a book published in 1966 by Robert Wilson called Feminine Forever. And he said, in essence, menopause is a hormone deficiency, totally preventable. Now, almost every woman, regardless of age, can safely live a full sex life for her entire life. And the idea was that if you've got a thyroid deficiency, how do you treat it? You give thyroid hormone. If you have insulin deficiency with type 1 diabetes, how do you treat it? You give insulin. If you have estrogen deficiency, what do you give? You give estrogen. Well, of course. So basically, every woman was recommended to get estrogen. Was there any basis for this? Yes. Observational studies looking at coronary and cardiovascular disease and hormone use were very optimistic. This is a nurses' health study. This was 120,000 women who were followed with surveys, which they filled out, questionnaires, every year or two for decades. And they started before menopause and continued through menopause and after. And what they found was estrogen replacement, which is blue, had a 50% reduction in cardiovascular disease, Progestin and estrogen, which was in the orange, was not quite as good. There was a blunting of the response, so it was only a 40% reduction. But still, there was a significant reduction in risk. The risk is 1 if it's average. If it's on this side, it's an increased risk. On this side, it's a decreased risk. And you can see there's a decreased risk. The conclusion was estrogen and estrogen plus progestin prevents heart disease in postmenopausal women. It is good for primary prevention. Well, if it was good for primary prevention, why wouldn't it be good for secondary prevention? Now, secondary prevention, remember, is where you already have the disease and you want to keep it from getting worse. This was the classic HERS study in 1998. The heart estrogen replacement study. And what they did, they randomized women to estrogen plus progestin or placebo, and these are women who already had heart disease. And what did they find? Women who were on the hormones actually had a worse outcome. If you already have plaque in your arteries and you go on the hormones, it's going to actually make you worse. Remember that. So the two things I want you to remember so far is progestin blunts the positive effect of estrogen, and if you already have heart disease, vascular disease, you're going to get worse. So when this was realized that hormone replacement therapy didn't help, the question was, is it really good for primary prevention? So why don't we do a prospective rather than observational study of primary prevention? And that is your Women's Health Initiative study, which was published just a few years ago. This involved 27,000 women aged 50 to 79. The primary concern was chronic disease prevention, and they looked at a variety of different diseases, not just heart disease. They excluded patients with significant vasomotor symptoms. Now that is interesting because what's the most common reason women go on hormone replacement is for vasomotor symptoms. The reason they excluded them was because if they had significant symptoms, they'd immediately know whether they were on placebo or whether they were on the hormones. But the fact is, they excluded them, and can you then generalize these findings to women who have vasomotor symptoms? They recruited patients from 1993 to 1998. They planned to end in 2005, but they ended in 2002. They had 3 groups of women: the control group who got neither estrogen or progestin, the study group with a uterus, estrogen plus progestin, and the study group who had already had a hysterectomy, they got only estrogen. What did they find? They found that there was an increase in blood clots, increase in strokes, increase in heart attacks, increase in breast cancer on women who were on estrogen plus progestin. There was a decrease in colorectal cancer. There was a decrease in hip fractures, a decrease in total fractures. But when they asked overall, is there a relative benefit or harm, the conclusion was that the harm outweighed the benefit, and the press that was given to this study was incredible. Combo hormone therapy linked to doubling the risk of thrombosis. And this went out throughout the media, and women started going off of the hormone therapy rapidly. Estrogen plus progestin worsens the outcome. If a woman does not have heart disease, it is not good for primary prevention. And that is the conclusion that was reached by the Women's Health Initiative. Now look at the data. These are comparison of the estrogen plus progestin group and the estrogen only group. And we're looking at vaginal dryness, hot flashes, vasomotor symptoms, osteoporosis, breast cancer, heart disease, and stroke. What we found was that both groups benefited in terms of vaginal dryness, hot flashes, vasomotor symptoms, and osteoporosis. The estrogen plus progestin group, however, did have a 25% increase in breast cancer. They had an increase in heart disease and an increase in stroke in the first year. Well, we knew that the stroke would be increased because of the HERS study. But notice the estrogen-only group. There was no change in breast cancer. There was no change in heart disease. Now, you're an intelligent, informed scientist. When you look at this data, where is the problem? Is it estrogen or is it estrogen plus progestin? And it looks to me that this is primarily a progestin problem. And what I will predict to you within the next few years, instead of giving progestin systemically, we're going to have a little Mirena IUD, levonorgestrel, which will fit into the uteruses of postmenopausal women, because that's really where they need the progestin, not systemically, because systemic progestin, it minimizes the effect, which is positive for the estrogen. For the purposes of the exam, you should answer, the only indication for estrogen or hormone therapy is vaginal dryness, hot flashes, vasomotor symptoms, never for osteoporosis or for heart disease. If a woman has no uterus, she doesn't need progestin, only estrogen. There's no need to prevent endometrial hyperplasia if she has no endometrium. If she has a uterus, she will need estrogen plus progestin. The recommendations for the exam are, the only indication for hormone therapy is vasomotor symptoms, never for prevention of cardiovascular disease, or osteoporosis. Use the lowest dose required, reevaluate on an annual basis, use for the shortest duration needed, reevaluate on an annual basis, and do not exceed, if possible, 4 years, because the breast cancer risk was not found prior to 4 years. This is what you should say on the exam. Now let me give you a little bit of different slant to this. You should use low dose, and this is low dose conjugated estrogens and medroxyprogesterone acetate. As doctors started to reanalyze this data, it didn't make sense with the Nurses' Health Study. Why was there such a difference? And the research suggests that timing may be the key. That it's not the hormones as much as when you start the hormones in terms of primary prevention. If you start them for younger women, they will probably get a benefit which the older women will not. This is an article which was published stating that women starting hormone therapy near menopause had a 30% reduction in heart disease compared to those without hormone therapy or those starting 10 years after. So don't wait to start it. The Nurses' Health Study showed that if you had early onset of estrogen, you did have a reduction in heart disease. Both the HER study and the Women's Health Initiative showed that if you give it to women who already have established heart disease, you're going to rupture the vulnerable plaques, and you're going to have a worse outcome. The Nurses' Health Study and the Women's Health Initiative showed that if you use systemic progestins, you actually have less of a protective effect. My criticism of the Women's Health Initiative is, one, they excluded patients with vasomotor symptoms, which is a main reason why women take this. Notice the average patient age, 63. What's the average age of menopause? 51. What happened in that 10-year window of opportunity? Were plaques laid down which weren't there at the beginning of menopause? And I suspect that they probably were. Same dose of hormone was used for all ages, and it's not true it was a primary prevention, because 40% of the patients actually had hypertension, 15% had elevated cholesterol, and a significant percentage had diabetes. In order to prevent disease, you really need to have tissues that are healthy to start. And if you wait beyond that window of opportunity, the critical period for maximum response, what do you think will happen? If you've already got established disease, you can't prevent it. Here is when hormones need to be started, at age 51, 52. What was the average age of the Women's Health Initiative? 63. What happened in this period of time? I think they started too late. And I think we need to do studies looking at the effect when you begin hormone therapy, right at menopause, not waiting for up to 10 years later. Estrogen seems to work by limiting the progression of atherosclerosis rather than by treating established disease. You cannot turn back the clock. And that, I think, is an important thing to remember for estrogen use. Alzheimer's, a major concern. This looks at the prevalence of Alzheimer's in men and women. You can see with advancing age, it is more and more prevalent, and it is twice as common in women as in men. There is suggestive evidence that estrogen replacement reduces the risk of Alzheimer's disease. This is an average relative risk of 1. This is 3 years of estrogen, 4 years of estrogen, and more. And you can see that there is a decline. I think that is an important issue that needs to be addressed. You can give estrogen either orally, and this is Prempro. This is the pills. These are tablets. Or you can do it transdermally through a patch. This has estrogen plus the progestin norethindrone. Recently, there's been an estrogen ring, which can be used for 3 months. And here is the estrogen ring. It's called a Fem ring, and it gives slow release of 3 months of estrogen. This is in the vagina, and I think this makes good sense. Remember, if a woman had her ovaries removed surgically, premenopausally or postmenopausally, she may be a candidate for both estrogen and testosterone. This is now available in the form of Estra test. And I've had a number of women who I have operated on who said that now that they're on the hormone estrogen plus testosterone, they can now boogie again. Their libido is back to what it was before. And that's the end of menopause.